Welcome to the Deep Dive, the show where we really dig into complex topics to give you those aha moments, the kind of insights you need to be truly well-informed.
That's the goal.
Today, our mission really is nothing short of mastering the intricate anatomy of the lower limb.
Yeah.
And we're not just talking basics here. We mean the kind of detailed understanding that elite professionals rely on every single day. You know, the robust framework, the mechanics, the surprising vulnerabilities, everything that lets us stand, walk, run.
And to really get a handle on this incredible system, we're going to start by diving into a pretty compelling real-world scenario.
Okay.
Imagine a young student, just 18 years old, doing a routine pizza delivery on his motorcycle. Okay?
Right.
Then suddenly a violent impact. A car bumper strikes the outer side of his left knee.
Ouch.
Yeah. And the immediate aftermath, it was stark. Extensive paralysis of muscles in both the anterior and the lateral compartments of his left leg.
Wow. So what did that mean practically for him?
Well, it meant he couldn't lift his foot upwards at the ankle, what clinicians call foot drop.
Foot drop, right?
And he couldn't turn his foot outwards, everett it. Plus, he had diminished sensation all down the front and side of his leg, across top of his foot and toes, even critically the inner side of his big toe.
But the x-rays were clear.
Interestingly, yes. Initial radiographs showed absolutely no bone fractures.
So no broken bones, but the severe loss of function. That sounds, well, a real puzzle for most people.
It would be. But for an expert physician, these very specific symptoms, combined with knowing how the injury happened, that blow to the lateral knee, it painted a clear picture.
So what was the diagnosis?
Paralysis of the common fibular nerve, caused by that blunt trauma to the lateral side of the left fibula. And the x-ray confirmed no fracture to the neck of the fibula itself.
Okay.
And, to reach that precise diagnosis, to really understand the implications for his recovery, and just to master the how and why of the body, physicians need this level of detailed anatomical knowledge.
And that's exactly what we're aiming for today, that professional level understanding.
Exactly. Our goal is to give you the foundational knowledge that underpins, well, every diagnosis, every treatment plan, every rehab strategy for the lower limb.
Right.
We're going to connect the anatomical dots to these clinical symptoms, help you understand not just what happened to our pizza delivery student, but why a specific injury in one tiny area can cause such a dramatic and actually quite predictable set of functional losses across the whole limb.
Okay, so to get that professional grasp, we'll explore the bony framework, the scaffold,
Yep, osteology.
the powerful muscle groups driving movement, the complex pathways of nerves and vessels energizing it all,
The neurovasculature, exactly.
and those remarkable joints that take our entire body weight. We'll also dissect common clinical conditions, look at radiographic insights, touch on surface anatomy.
Which is crucial for examination.
Right. All tying back to the incredible resilience, but also the occasional vulnerabilities of the lower limb, giving you that complete integrated view.
That's the plan, a comprehensive mastery.
Okay, let's start with the big picture then. The lower limb itself. It's engineered for locomotion. What are its core functions?
Fundamentally, the lower limbs are, you could say, the pillars of our existence. They serve two absolutely indispensable roles.
Okay.
First, they support the entire weight of our body. That allows us to stand upright against gravity.
Makes sense.
Second, they're the primary engine for locomotion, whether that's just balancing while standing, the rhythm of walking, or the power needed for running.
And there's an inherent stability built in, right? You mentioned the hip bones.
Yeah, what's really remarkable is that stability. The paired hip bones, the os coxae, they articulate posteriorly with the trunk at these incredibly strong sacroiliac joints. And then anteriorly, they meet each other at the symphysis pubis. This whole structure, this robust bony ring, the pelvic girdle, forms this incredibly strong foundation for our upright posture and all our dynamic movements.
So it's strong and it's organized, broken down into specific regions.
Precisely. Each lower limb is meticulously organized into 6 main regions that, professionals really need to master.
Which are?
The gluteal region, the buttock, the thigh, the popliteal fossa, that diamond shape behind the knee,
Right.
the leg proper, so between the knee and ankle, then the ankle itself, and finally the foot.
Okay.
And what's critically important at the thigh and the leg, particularly from a clinical standpoint, is their internal compartmentalization.
Ah, the compartments.
Yes, each compartment is like a distinct anatomical suite. It houses a specialized group of muscles, its own dedicated nerve supply, and its specific blood supply and drainage.
Very efficient design.
It's elegant, yeah. Allows for highly specialized functions. But, and here's where it gets really interesting, clinically, this very compartmentalization also creates specific vulnerabilities. Well, if trauma or swelling happens inside one of these tightly bound spaces, the pressure can build up rapidly. And that pressure can compromise the delicate nerves and blood vessels trapped within that compartment. That can lead to really serious functional problems like compartment syndrome, which we'll definitely touch on. It relates back to our student's case, too, in a way.
Right, that makes sense. Efficient, but potentially risky if things go wrong inside. And you said lower limb problems are super common.
Oh, absolutely. Which makes this deep dive so essential. Lower limb issues are among the most frequent things health professionals deal with every single day.
Like what kind of things?
Well, the range is huge. Degenerative stuff like various forms of arthritis, vascular problems, varicose veins are common, but also more severe vascular deficiencies. Trauma, of course, is rampant. Fractures, dislocations, sprains, lacerations. Then you see things like knee effusions, fluid on the knee, generalized leg pain, countless ankle injuries, and of course, peripheral nerve injury.
Like our pizza delivery student.
Exactly like his common fibular nerve injury. So mastering the detailed anatomy we're covering today gives you the essential context to understand the what, the why, and the how behind all these conditions. It really lays the groundwork for professional-level clinical thinking.
Okay, so let's build that foundation. We have to start with the bones, the osteology. You said it's similar to the upper limb, but adapted for weight bearing.
That's a great starting point. The bones, the os coxus, femur, patella, tibia, fibula, the tarsals, metatarsals, phalanges, they do follow a similar general pattern to the arm and hand.
Right.
But their whole design, their architecture, is fundamentally geared towards stability and efficiently bearing and transmitting body weight. That's different from the upper limb, which is all about dexterity and fine motor control.
And the pelvic girdle is key here.
Absolutely. The paired os coxae, the hip bones, along with the sacrum at the back, form this strong pelvic girdle. That's the crucial, resilient attachment point for the entire lower limb to the spine. It's the bedrock of our upright posture.
Okay, let's zoom in on the os coxae itself, the hip bone. It's actually 3 bones fused together.
Indeed. It's a complex, large, quite irregularly shaped bone formed by the fusion of 3 distinct elements.
Sure.
You have the ilium, that's the broad, fan-shaped upper part. The ischium, the L-shaped posterior and inferior part, basically what you sit on.
Okay.
And the pubis, the anterior medial component. These 3 bones all converge and meet in that deep cup-shaped socket called the acetabulum.
The hip sockets.
Exactly, which is crucial for the hip joint. In younger people, they're separated by a Y-shaped piece of cartilage, the triradiate cartilage, which fuses in adulthood.
And these hip bones connect to form the pelvis.
Right. They articulate posteriorly with the sacrum at the sacroiliac joints and anteriorly with each other at the symphysis pubis, forming the strong walls of the pelvic bowl.
When we look at the outside of this bone, what are the key features, the landmarks that clinicians really need to know? For palpation, for understanding where things are?
For professionals, identifying surface landmarks is absolutely critical. On the outer gluteal surface, the iliac crest is easily palpable along its whole length. It's a major muscle attachment site and guides palpation.
Okay.
It ends anteriorly at the anterosuperior iliac spine, the ASIS of vital landmark, and posteriorly at the posterior superior iliac spine, PSIS.
ASIS and PSIS, got it.
Yeah. About 2 inches behind the ASIS, you can often feel the iliac tubercle. Below the ASIS is the antero-inferior iliac spine. The ilium also forms that large curve, the greater sciatic notch.
And the ischium, the sitting bone.
Right. The ischium has the ischial spine projecting back, separating the greater and lesser sciatic notches. And below that is the prominent ischial tuberosity. That's the large roughened area forming the buttocks prominence. And critically, it bears our weight when we sit.
Okay. And the pubis?
The pubis has a body, a superior ramus joining the ilium and ischium at the acetabulum, and an inferior ramus joining the ischial ramus below the big hole, the obturator foramen. Key palpable points anteriorly are the pubic crest and the pubic tubercle.
And the acetabulum itself, the socket, how is it structured for the femur?
It's a deep depression, perfectly shaped for the almost spherical head of the femur. Its lower edge is incomplete. That's the acetabular notch, which is bridged by the transverse acetabular ligament. The actual joint surface is horseshoe-shaped, covered with smooth hyaline cartilage for low friction. The central floor, the acetabular fossa, isn't part of the joint surface. It's non-articular and filled with fat.
Okay.
and a crucial point for understanding alignment. In the correct anatomical position, the front of the symphysis pubis and the ACES lie in the same vertical plane. This orientation is vital for analyzing posture and planning surgery.
All right, moving down from the pelvis, we get to the femur, the thigh bone. Longest, strongest bone in the body, you said. Critical for both hip and knee.
Absolutely. The femur connects the hip to the knee. Superiorly, it articulates with the acetabulum, the hip joint. Inferiorly, with the tibia and the patella, the knee joint.
Let's look at the upper end. Head, neck, trochanters.
Right. The head is almost 2/3 of a sphere, fitting snugly into the acetabulum. In its center is the fovea capitis, a small pit where the ligament of the head attaches.
Ligament of the head.
Yeah, and what's interesting here, especially for professionals, is that a small branch of the obturator artery runs along this ligament to supply part of the femoral head. This is particularly important in children.
Okay.
The neck connects the head to the shaft. It angles downward, backward, and laterally at about 125 degrees in adults. That angle is crucial and can change with age or disease.
And the trochanters.
The greater and lesser trochanters are large bumps at the junction of the neck and shaft. They're powerful attachment sites for muscles. They're connected anteriorly by the intertrochanteric line and posteriorly by the prominent intertrochanteric crest.
The shaft of the femur, smooth in front, but ridged behind.
Exactly. Smooth and rounded anteriorly. But posteriorly, it's marked by this prominent longitudinal ridge, the linea aspera.
Linea aspera.
Yeah, it's a vital attachment site for numerous muscles and the intermuscular septa that actually divide the thigh compartments. The edges of the linea aspera spread out at the top and bottom. Proximally, they enclose the gluteal tuberosity, and distally, they broaden to form a flat, triangular area called the popliteal surface, just above the knee.
And then the lower end flares out into the condyles for the knee joint.
Right. It expands into the prominent lateral and medial condyles. They're separated posteriorly by the deep intercondylar notch. Anteriorly, they join to form the articular surface for the patella, the kneecap. Just above the condyles are the medial and lateral epicondyles. And there's a distinct bump continuous with the medial epicondyle called the adductor tubercle.
Now, clinically, for the professional, the femur is obviously huge.
Yeah.
Can you actually palpate the head of the femur?
You can, actually, and this is key for physical exams. The part of the femoral head that isn't deep inside the acetabulum can be felt on the anterior thigh. It's just below the inguinal ligament and lateral to the pulsating femoral artery.
And finding tenderness there means?
Tenderness in that specific spot is a significant sign. It often strongly suggests arthritis within the hip joint itself.
Okay. And when we talk about fractures, especially at the femoral neck, blood supply is a massive issue, right? A vascular necrosis.
This is a critical point for patient outcomes. A vascular necrosis, bone death due to lack of blood supply, is a severe complication after femoral neck fracture.
Why does it happen?
Well, in adults, the main blood supply to the upper part of the femoral neck comes from these tiny retinacular branches of the medial femoral circumflex artery. These pierce the joint capsule.
Okay.
A fracture of the femoral neck, especially a subcapital one right under the head, very often tears these crucial arteries. If that little artery in the ligament of the head isn't enough to keep the bone alive, which it often isn't in adults, then ischemic necrosis, the bone death, gradually happens. It's a really common and serious issue, especially in elderly women, often linked to osteoporosis. It shows that interplay between anatomy, age, and systemic health that professionals have to grasp.
And the angle of the neck matters too. Kukavalga, Koksavara.
Absolutely. That neck shaft angle, normally about 125 degrees in adults, is important. If the angle increases, that's Koksavälga, it can limit how far the hip adducts, turns inward, sometimes seen in congenital hip dislocation.
Okay.
If the angle decreases Koksavara, it limits abduction, turning outward, often seen after femoral neck fractures or if the growth plate slips in adolescence.
And there's a way to check this on X-ray.
Yes, Shenton's line. It's a continuous curve you trace on an X-ray, following the bottom edge of the femoral neck and the top edge of the obturator foramen. If that line is broken or uneven, it indicates a potential fracture or abnormal angle. It's a vital radiographic tool for orthopedists.
Femur fractures themselves, they're diverse.
Yeah.
And you mentioned the muscles pull the fragments into specific positions.
It's absolutely critical for surgeons to understand this biomechanics. Take femoral neck fractures, common in the elderly, high risk of that of vascular necrosis we mentioned. If the fragments aren't jammed together, they displace predictably. The powerful thigh muscles, rectus femoris, adductors, hamstrings, pull the distal fragment upwards, shortening the leg.
Right.
And at the same time, the gluteus maximus and the deep lateral rotators, piriformis, obturators, gemelli, quadratus femoris, rotate that distal fragment outwards. Clinically, you see the patient's toes pointing laterally.
Okay. What about shaft fractures?
Shaft fractures, usually in younger people from significant trauma, show even more dramatic muscle pull.
Yeah.
If it's in the upper third.
Yeah.
The proximal bit gets pulled into flexion by the iliopsoas, abducted by the gluteus medius and minimus, and laterally rotated by the gluteus maximus and deep rotators. The distal fragment gets pulled upwards, adducted, and laterally rotated. It's complex.
Wow. And mid or lower third?
Middle third fractures see the distal fragment pulled way up by hamstrings and quads, causing significant shortening, and rotated backward by the calf muscle, the gastrocnemius. If the fracture is in the distal third, closer to the knee, that backward rotation by the gastrocnemius is even greater. And this is clinically critical because that displaced fragment can compress the popliteal artery running behind the knee.
Cutting off blood supply.
Potentially, yes. It could compromise blood flow to the entire lower leg and foot. So knowing these specific muscle actions is indispensable for understanding how the fragments move and for applying the correct traction to pull things back into alignment before surgery. That's applied anatomy mastered by professionals.
That's a fantastic example. Okay, moving to the patella, the kneecap. It's not just floating there, it's embedded in the quadriceps tendon.
Exactly. The patella is the largest sesamoid bone, meaning it develops within a tendon, specifically the powerful quadriceps femoris tendon. It sits right in front of the knee joint.
Right.
It's triangular, apex pointing down, connecting to the tibial tuberosity via the ligamentum patellae. Its back surface articulates with the femoral condyles. It's very exposed, easily palpable, separated from the skin only by the prepatellar bursa.
And clinically, dislocations, fractures.
Yeah, its position and muscle attachments dictate its issues. Patellar dislocations are common. Normally, the lower fibers of the vastus medialis muscle and the large lateral femoral condyle prevent it from sliding outwards, laterally.
Okay.
So congenital dislocations often involve an underdeveloped lateral condyle. Traumatic ones can happen from direct hits or a sudden violent quad contraction.
And fractures.
Fractures can be from direct violence, like hitting the dashboard in a car accident, often causing multiple small fragments. Its closeness to the skin means a higher risk of an open fracture. Or indirect violence, like a sudden quad pull over a bent knee, can cause a transverse fracture, often with the fragments pulling apart.
Okay, next up, the tibia, the shin bone, major weight bearer.
The tibia is the large medial weight-bearing bone of the leg. It articulates up top with the femur condyles and the fibula head, and down below with the talus and the distal fibula.
The top part, the tibial plateau.
Right. Its expanded upper end has the lateral and medial condyles, clinically called the tibial plateaus. They articulate with the femoral condyles and the menisci, those cartilage shock absorbers. Between the plateaus are the intercondylar areas and the intercondylar eminence, crucial attachment points for the cruciate ligaments. The lateral condyle also has a small facet for the fibula head.
And the shaft, the shin part. What's key there?
The shaft is triangular in cross-section. Its anterior border and medial surface, the bit between them, is entirely subcutaneous.
That's the shin we feel.
Exactly. And that makes it very vulnerable to direct hits and open fractures. At the top of the anterior border is the tibial tuberosity, where the ligamentum patellae attaches. Posteriorly, there's an oblique ridge called the soleal line for the soleus muscle.
And the lower end.
The lower end is slightly expanded. It has a saddle-shaped surface underneath for the talus. Medially, it extends down as the large medial malleolus, the inner ankle bone. Laterally, there's a rough area where it articulates with the fibula.
Given its prominence, tibial fractures must be common, and you mentioned specific complications.
Yeah, its anatomy really influences fracture patterns. Fractures of both tibia and fibula are common. If just one breaks, the other can act like a splint. But tibia shaft fractures are often open fractures because that medial surface is right under the skin.
Right.
And fractures in the distal third of the shaft are notorious for delog union or non-union.
Why is that?
Couple of reasons. The nutrient artery, a key blood supply, might get torn. And if the fibula is intact, it can sometimes hold the tibia fragments slightly apart, preventing good healing.
Okay, and up top, the plateau fractures.
Fractures of the tibial condyles, the plateau, are also common, especially in middle-aged or older people, usually from a direct blow to the side of the knee, like getting hit by a car bumper. They can be split, crushed, or involve the intercondylar eminence, complex injuries requiring careful surgery.
And finally, the fibula, the slender lateral bone. Doesn't bear weight, you said?
That's correct. The fibula is slender, sits laterally. It doesn't participate in the knee joint or transmit body weight, but it's still vital.
Oh, so?
It provides numerous muscle attachments, especially for the lateral and anterior leg compartments. And crucially, it forms the lateral malleolus, the outer ankle bone, which is essential for ankle joint stability.
Got it. Upper end is the head.
Right. The head has a styloid process and articulates with the tibia's lateral condyle. The shaft is long and thin, with an interosseous border for that membrane connecting it to the tibia. The lower end forms that triangular lateral malleolus, which is subcutaneous and articulates with the talus. There's a little pit behind it called the malleolar fossa.
Okay, moving down again to the foot. Tarsals, metatarsals, phalanges. Similar layout to the hand, but adapted for weight bearing.
Exactly. The general grouping mirrors the hand, but the adaptations for weight bearing, shock absorption, and propulsion are profound. One interesting point for professionals is ossification. Unlike the wrist bones, the tarsal bones start ossifying before birth. Centers for the calcaneum, talus, and often the cuboid are usually present at birth. All are ossified by age 5.
Let's break down the tarsals, which are the key players.
The tarsals include the calcaneum, talus, navicular, cuboid, and the 3 cuneiforms. Critically, only the talus articulates with the tibia and fibula to form the true ankle joint.
Okay, calcaneum.
The calcaneum is the heel bone, the largest foot bone, articulates above with the talus, in front with the cuboid. Key features include the sustentaculum tali on its medial side, which actually supports the talus, and the peroneal tubercle laterally, separating the fibularis longus and brevis tendons.
And the talus itself, you said it's unique.
What's truly fascinating here for professionals is the talus. It connects the leg to the foot, articulates with tibia and fibula above, ankle joint, calcaneum below, and navicular in front. It has a head, neck, and body. But here's the key thing. While lots of important ligaments attach to it, absolutely no muscles attach directly to the talus.
No muscles at all. Wow.
None. Its position and movement are entirely dictated by the bones around it and the ligaments holding it. Its head rests partly on the sustentaculum tali. Its neck has a groove, the sulcus tali, which forms the sinus tarsi with the calcaneum housing a strong ligament. The body articulates with the tibia and malleoli and has a posterior groove for the flexor hallucis longus tendon.
Any other key tarsal landmarks?
Yes. The tuberosity of the navicular bone is easily palpable medially, about an inch below and in front of the medial malleolus. It's the main attachment for the tibialis posterior tendon, crucial for the arch. The cuboid bone has a groove underneath for the fibularis longus tendon as it crosses the sole. And the 3 wedge-shaped cuneiform bones articulate with the navicular behind and the first 3 metatarsals in front. Their wedge shape is vital for the transverse arch of the foot.
Then we get to the metatarsals and phalanges, making up the body of the foot and toes.
Right, they broadly resemble the hand bones. Head distally, shaft, base proximally, numbered 1 to 5, medial to lateral.
That's metatarsal.
For the big toe, the hallux. It's large, strong, critical for weight support. Its head has grooves underneath for 2 little sesamoid bones in the flexor hallucis brevis tendons.
And the 5th?
The 5th metatarsal has a prominent tubercle on its base, easily felt laterally. That's where the fibularis brevis tendon attaches a common spot for avulsion fractures, as we mentioned.
Right. And toes have 3 phalanges, except the big toe.
Correct. Just like the thumb, the hallux only has 2 phalanges. The other 4 toes have 3.
Injuries to these foot bones seem common, and the mechanism matters.
What's fascinating is how specific forces cause specific fractures, which pros learn to recognize instantly. Talus neck fractures often happen from violent dorsiflexion, jamming the neck against the tibia.
Okay.
Calcaneum compression fractures are classic fall from a height injuries. The talus drives down, crushing the calcaneum, making it shorter and wider.
And metatarsals.
The base of the 5th metatarsal fracture, we talked about forced inversion, pulls the fibularis brevis tendon off. Stress fractures are also super common, especially in runners, usually in the distal third of the 2nd, 3rd, or 4th metatarsals. Often minimal displacement because the interosseous muscles hold things together.
All right, let's pivot up to the gluteal region, the buttock. Powerful area, important landmark.
The gluteal region, bounded by the iliac crest above and the buttock fold below. Mostly made of the gluteal muscles and thick superficial fascia. It's a region of immense power, critical for standing, walking, running.
And the fascia here is important too.
What's interesting is how fascia shapes this region. The superficial fascia is thick, especially in women, lots of fat contributing to the prominence. Deep to that is the deep fascia, the fascia lata, continuous with the thighs fascia.
Hmm.
It actually splits to enclose the big gluteus maximus muscle. Above the maximus, it covers the gluteus medius and attaches to the iliac crest.
And then there's that iliotibial tract, or IT band, more than just a simple band.
Oh, definitely. The iliotibial tract is a strong, wide thickening of that fascia lata on the lateral thigh. Attaches up high to the iliac tubercle, runs all the way down to the lateral tibial condyle.
Yep.
It acts as a sheath for the tensor fasciae latae muscle, and crucially, it receives most of the insertion of the gluteus maximus. This makes it a powerful stabilizer and helps extend the knee, especially when walking or running.
The ligaments in this region stabilize the pelvis, but they also form openings foramina for nerves and vessels.
Yes, these are essential structures. The sacrotuberous and sacrospinous ligaments are strong bands stabilizing the sacrum, preventing it from rotating under body weight. And their arrangement, along with the notches in the hip bone, creates the greater and lesser sciatic foramina. These are anatomical gateways.
So the greater sciatic foramen, what critical structures pass through that professionals need to know?
This is vital. It's the main exit from the pelvis into the gluteal region. Key contents include the piriformis muscle, the massive sciatic nerve,
The big one?
the superior and inferior gluteal nerves and vessels, the pudendal nerve and its internal pudendal vessels. The piriformis muscle is often used as a landmark here.
And the lesser sciatic foramen.
That allows structures that just exited the greater foramen, like the pudendal nerve, internal pudendal vessels, and the obturator internus tendon to loop back into the perineum from the gluteal region, a critical pathway for innervating and supplying the perineum.
Okay, the muscles themselves. Gluteus maximus, medius, minimus. Powerful group. Clinical relevance.
Absolutely. The gluteal muscles include the maximus, medius, minimus, and tensor fasciae latae, plus deeper ones like piriformis. Gluteus maximus is the largest muscle in the body, superficial, gives the buttock its shape. Powerful hip extensor and lateral rotator, think standing up from a chair or climbing stairs.
And it's a common injection site, but needs care.
This raises a really important point for safe practice. The gluteus maximus is thick, great for IM injections, but the sciatic nerve runs deep to it, so injections must be given well forward in the upper outer quadrant of the buttock. This avoids hitting that nerve, which could be devastating. Direct application of anatomical knowledge.
And the gluteus medius and minimus, key for stable walking.
Yes, the gluteus medius and minimus, supplied by the superior gluteal nerve, are critical hip abductors and medial rotators. If they're weak or paralyzed, maybe from nerve injury or polio, the person can't stabilize their pelvis when walking. This causes the pelvis to dip down on the unsupported side when they stand on the affected leg. That's the positive Trendelenburg sign. Leads to a characteristic dipping or waddling gait. Shows just how crucial these muscles are for normal walking, a key diagnostic sign for professionals.
Speaking of nerves, the gluteal region is a highway for nerves from the sacral plexus. Sciatic nerve is the main one.
The sciatic nerve formed from L4, L5, S1, S2, S3 is indeed the largest nerve in the body. It's essentially the tibial and common fibular nerves bundled together. It exits the pelvis through the greater sciatic foramen, usually below the piriformis.
Okay.
Then it curves down and laterally, deep to gluteus maximus, heading for the back of the thigh. Importantly, it usually gives off no branches in the gluteal region itself. It's mainly a conduit, making its health vital for everything downstream.
What about blood supply? Any important connections and anastomoses here?
What's fascinating is the rich blood supply and the vital backup networks. The superior gluteal artery, above piriformis, and inferior gluteal artery, below piriformis, both from the internal iliac artery, supply the gluteal muscles.
Okay. And they contribute to two significant collateral networks around the hip, crucial safety nets if an artery gets blocked. The trochanteric anastomosis is key for supplying the femoral head, involving gluteal and circumflex femoral arteries. The cruciate anastomosis, near the lesser trochanter, connects the internal iliac and femoral systems. Professionals know these networks are vital for keeping the femoral head and thigh supplied, especially after things like femoral neck fractures. Okay, let's transition down into the thigh itself, the main lever between hip and knee. The fascia here is important clinically, too.
The thigh fascia is highly organized and very relevant clinically. The superficial fascia has a fatty layer, continuous with the abdomen, but deeper, the membranous layer attaches firmly to the deep fascia, the fascia lata, about a finger's width below the inguinal ligament.
Why is that attachment point important?
It dictates where fluids can spread. For example, If urine extravasates after a urethral rupture, knowing this fascial attachment tells you where that urine is likely to track, which is crucial for diagnosis and management.
So the deep fascia, the fascia lata, is like that tight sleeve again.
Exactly. The fascia lata encloses the thigh tightly, attaches up top to the pelvis and inguinal ligament. Laterally, it thickens massively to form that strong iliotibial tract we mentioned.
Right, the IT band.
Attaches to the iliac tubercle above, runs down to the lateral tibial condyle below. It sheaths the tensor fasciae latae muscle and gets most of the gluteus maximus insertion. Powerful stabilizer.
And there's an opening in this fascia, the saphenous opening.
Yes, anteriorly, just below the inguinal ligament, there's a gap called the saphenous opening. It's covered by looser cribriform fascia. It's the gateway for the great saphenous vein to dive deep and join the femoral vein. Also transmits small artery branches and lymph vessels. It's located about 1.5 inches below and lateral to the pubic tubercle.
The thigh has extensive skin innervation too. Any key nerves clinicians focus on?
Yeah, the pattern is segmented. Key ones include the lateral cutaneous nerve of the thigh, L2-3 for the lateral skin, the medial and intermediate cutaneous nerves of the thigh, branches of the femoral nerve, cover the front and medial aspects. The saphenous nerve, also from the femoral, takes over the lower medial leg. Knowing these territories helps diagnose nerve issues or referred pain.
Okay, now this is really interesting clinically. The superficial veins, especially the great saphenous vein, hugely important.
What's fascinating is its consistent path and massive clinical role. The great saphenous vein starts on the foot, runs up the medial leg right in front of the medial malleolus, passes behind the knee, curves around the medial thigh, then dives through that saphenous opening to join the femoral vein. It has valves and connects to deep veins via perforating veins.
And this relates to varicose veins.
Absolutely. It's key to the lower limb venous pump. Muscle contraction squeeze deep veins, pushing blood up. Valves in those perforating veins normally only let blood flow from superficial to deep.
Yeah.
If those valves fail, or if there's high pressure, you get varicose veins, those enlarged, twisty superficial veins. Very common condition professionals manage.
And the great saphenous is used in surgery too.
Precisely. Great saphenous vein cut-down is a standard emergency access technique at the ankle or groin due to its reliable location. But even more critically, it's frequently harvested for coronary artery bypass surgery or for bypassing blocked arteries elsewhere, like the femoral. They reverse it so the valves don't block flow. After it's removed, superficial blood just reroutes through perforators to the deep system, shows the body's adaptability.
The inguinal lymph nodes are also critical here. Drainage system, diagnostic clues.
Yes, the inguinal nodes, superficial and deep, are key immune surveillance points. The superficial ones, below the inguinal ligament, drain a huge area.
Like what?
The medial ones get lymph from the lower anterior abdominal wall, the perineum, including urethra, external genitalia but not testes, lower anal canal. Lateral ones get lymph from the back below the iliac crests. The vertical group along the saphenous vein gets most lymph from the leg.
And they drain deeper.
Right. Efferents go through the saphenous opening to the deep inguinal nodes, which lie along the medial side of the femoral vein. These also get lymph from deep leg structures. Then they drain up into the abdomen.
So an issue in the groin could mean something far away.
This highlights a crucial diagnostic principle. These nodes drain the whole lower limb, lower abdomen, external genitalia, lower anal canal. So an enlarged, painful inguinal node could be from a simple scratch on the toe or critically something serious like an anal canal carcinoma. Requires thorough investigation.
Let's talk thigh compartments now, like anatomical rooms with specific contents.
Excellent analogy. 3 strong fascial septa run from the deep fascia lata to the linea aspera on the femur, dividing the thigh into anterior, medial, and posterior compartments. Fundamental organization. Each has its own muscles, nerves, arteries, specialized functions.
Focusing on the anterior compartment, muscles, actions.
Anterior compartment houses the sartorius, iliopsoas, iliacus plus psoas major, pectineus, and the big one, quadriceps femoris.
The quad.
Right. 4 heads. Rectus femoris, vastus lateralis, vastus medialis, vastus intermedius. Blood supply is the femoral artery. Nerve supply is the femoral nerve.
And the action.
Primarily powerful knee extension via the patella and ligamentum patellae. The lowest fibers of vastus medialis are key to keeping the patella tracking properly. Rectus femoris is unique. It also flexes the hip, a pro-level detail.
The quad is vital for knee stability, right? Its health is a clinical sign.
What's fascinating is the quad isn't just the main extensor, it's the most crucial stabilizer for the knee. Its muscle tone massively strengthens the joint.
So clinically.
In any suspected knee problem, you must examine the quads on both sides. Check size, firmness, strength. Muscle atrophy, measured by thigh circumference, is a big red flag. And the vastus medialis often wastes first and recurs last in knee disease. Key clinical detail for rehab. Specific injuries like rectus femoris rupture or patellar ligament rupture can happen with sudden forces too.
Moving to the femoral triangle. Critical landmark, gateway for vessels and nerves.
The femoral triangle is that depression in the upper medial thigh, just below the inguinal ligament. Boundaries are key. Inguinal ligament superiorly, sartorius laterally, adductor longus medially.
Cool.
Floor is iliopsoas, pectineus, adductor longus. Major contents: femoral nerve, femoral sheath, containing femoral artery and vein, and deep inguinal nodes. Crucially, the femoral nerve lies outside the femoral sheath.
And just beyond that is the adductor canal, another passageway.
Right, the adductor or subsartorial canal, an intermuscular space on the medial mid-thigh, deep to sartorius. Starts at the femoral triangle's apex, ends at the adductor hiatus, an opening in the adductor magnus muscle.
What passes through?
Vital conduit. Contains the end part of the femoral artery, the femoral vein, deep lymph vessels, the saphenous nerve, the nerve to vastus medialis, and the end of the obturator nerve.
Now, the femoral sheath. Key structure, potential weak spot leading to femoral hernias.
What's fascinating here is the femoral sheath itself. It's a downward funnel of abdominal fascia. Encloses the femoral vessels and lymphatics for about an inch below the inguinal ligament. Divided into 3 compartments.
Lateral, intermediate, medial.
Right. Lateral for the femoral artery. Intermediate for the femoral vein. And the most medial is the femoral canal just for lymph vessels, remember? Femoral nerve is not in the sheath.
Okay.
That femoral canal, only half an inch long, is the potential weak spot. Its upper opening is the femoral ring. Because there's space around the lymph vessels, a bit of peritoneum can bulge down, creating a femoral hernia.
And femoral hernias are serious.
Yeah.
Careful diagnosis.
They are, more common in women. The hernia sac comes down the canal, swells in the upper thigh. Key differentiation: its neck is below and lateral to the pubic tubercle. Inguinal hernia is above and medial. The narrow neck at the femoral ring makes it prone to getting stuck, irreducible, or worse. Strangulated blood supply to bowel gets cut off. Surgical emergency. Professionals must also rule out other groin lumps. Swollen nodes, saphenous varix, pus tracking down, femoral artery aneurysm.
Okay, blood supply to the anterior compartment, mainly the femoral artery.
The femoral artery is the main feed for the whole lower limb. Enters the thigh under the inguinal ligament, midway between asus and pubic symphysis. Pulsations are easily felt there, key diagnostic point. Descends vertically, eventually goes through the adductor hiatus to become the popliteal artery. Relations are key. Femoral vein is medial initially, femoral nerve is lateral. Its biggest branch is the profunda femoris artery.
Profunda femoris.
Yeah, the deep femoral artery. Builds off medial and lateral femoral circumflex arteries, plus 4 perforating arteries. Provides rich supply to the deeper thigh, great collateral network.
Catheterizing these femoral vessels is common.
What's fascinating is their utility. Femoral artery catheterization lets you guide wires and catheters up into the aorta for angiography or pressure checks. Femoral vein catheterization gives rapid access to a large vein.
Right.
Its consistent spot medial to the artery makes it easy to cannulate. But there's a significant risk of thrombosis and pulmonary embolism, so catheters are usually removed once the patient is stable. High-stakes procedure.
Nerve supply to the anterior compartment, the femoral nerve.
The femoral nerve, largest branch of the lumbar plexus, L2-3-4, is the boss here. Emerges lateral to psoas, enters the thigh lateral to the femoral artery outside the femoral sheath.
Okay.
Splits into anterior and posterior divisions about 1.5 inches down. Its branches supply all the anterior compartment muscles, powerful knee extension, quads, hip flexion, rectus femoris, sartorius, iliopsoas. Its key sensory branch, the saphenous nerve, runs down the medial leg and foot.
Moving to the medial fascial compartment now. Adductors.
This compartment houses the gracilis, adductor longus, adductor brevis, adductor magnus, and obturator externus. Primary action, adduction of the thigh.
Blood and nerve supply.
Blood from profunda femoris and the obturator artery. Nerve supply, mainly from the obturator nerve. But interestingly, part of the big adductor magnus muscle gets innervation from the tibial nerve, reflects its dual origin.
And that adductor hiatus is in the adductor magnus.
Yes, a critical gap in its attachment to the femur. allows the femoral vessels to pass from the adductor canal into the popliteal space behind the knee.
And specific clinical interventions relate to these muscles. Cerebral palsy.
This raises an important point for neurological conditions. In cerebral palsy with severe adductor spasticity, surgeons often perform a tenotomy, cutting the adductor longus tendon, sometimes combined with dividing the anterior branch of the obturator nerve.
Why?
To overcome the spasm, improve limb position, aid rehabilitation, shows how anatomical knowledge translates directly into therapy.
Finally, the posterior fascial compartment. Hamstrings.
This compartment is defined by the hamstrings, biceps femoris, semitendinosus, semimembranosus, and the hamstring part of the adductor magnus. Rich blood supply from the four perforating branches of the profunda femoris.
Nerve supply.
All from the sciatic nerve. Specifically, the tibial nerve part supplies the long head of biceps, semitendinosus, semimembranosus, hamstring part of adductor magnus. The common fibular nerve part supplies only the short head of biceps femoris. That dual innervation of biceps is a key detail.
Actions.
Powerful knee flexors and hip extensors, crucial for running, climbing.
And the sciatic nerve itself runs through here.
What's fascinating is its path. Leaves the gluteal region, descends right down the midline of the posterior thigh, deep to the hamstrings, usually ends in the lower third of the thigh by splitting into the tibial and common fibular peroneal nerves, sometimes splits higher. Both then continue into the popliteal fossa.
Okay, let's follow them into the popliteal fossa, that diamond space behind the knee. Critical crossroads.
The popliteal fossa is indeed a fascinating space behind the knee, most obvious when bent. Vital connection between thigh and leg. Contents are dense and clinically vital. Popliteal vessels, end of the small saphenous vein, common fibular and tibial nerves, posterior cutaneous nerve of thigh, lymph nodes, boundaries formed by hamstrings above, gastrocnemius heads below.
And the popliteus muscle in there has a special job, unlocking the knee.
What's fascinating is the popliteus. It actually arises inside the knee joint capsule. Its tendon separates the lateral meniscus from the lateral ligament.
Okay.
This lets it not only flex the knee, but also produce medial rotation of the tibia on the femur. That rotation is crucial for unlocking the fully extended knee, slackening ligaments so flexion can start. It also pulls the lateral meniscus back during flexion.
The popliteal artery runs through here too, continuation of the femoral.
Yes, the popliteal artery is deep, continues from the femoral via the adductor hiatus, ends at the lower edge of popliteus by splitting into anterior and posterior tibial arteries. Relations are key. Lies on femur, knee joint, popliteus muscle, popliteal vein, and tibial nerve are behind it.
Branches.
Anastomosis gives muscular branches and multiple genicular branches, forming a rich arterial network around the knee. Essential backup because the main popliteal artery gets squeezed during deep knee bending. Professionals know popliteal aneurysms can form here.
Nerves passing through this crossroads. Sciatic divides above. Both branches continue down.
That's right. Sciatic usually splits into tibial and common fibular nerves above the fossa. Both then pass through. The tibial nerve is larger, runs down the middle, crossing behind the popliteal artery, gives off the sural nerve for the calf and lateral foot skin, and muscle branches to gastrocnemius, plantaris, soleus, popliteus.
And the common fibular nerve, this is the one relevant to our student.
What's truly fascinating, and directly links to our pizza delivery student, is the common fibular peroneal nerve, smaller branch, runs down along the medial edge of biceps femoris, leaves the fossa, passes behind the fibula head, and then critically winds laterally around the neck of the fibula.
That's the vulnerable spot.
Extremely vulnerable. It's subcutaneous, right against the bone, easily injured by direct trauma like that car bumper or fibula neck fractures, even tight casts. After winding around, it pierces fibularis longus muscle and splits into superficial and deep fibular nerves.
So connecting back this specific injury location explains his symptoms.
This brings us back to the student with perfect clarity. Injury right there at the fibula neck directly causes paralysis of muscles in both the anterior and lateral leg compartments.
Which muscles?
Tibialis anterior, the extensors, fibularis tertius from the deep fibular nerve, and fibularis longus and brevis from the superficial fibular nerve.
Resulting in
The opposing muscles, the plantar flexors and invertors, are unopposed, so the foot is pulled down and inward equinovarus. That causes a classic foot drop. Can't lift the foot.
and the sensory loss.
Matches perfectly. Loss down the anterior and lateral leg, top of the foot and toes, including the inner side of the big toe. Exactly what the student had. A clear anatomical explanation, professional level insight right there.
Okay, let's move into the leg proper now. Knee to ankle. Unique architecture here, too.
The leg is distinct. Its deep fascia is crucial, forms the compartments, but also ankle retinacula, fibrous bands that act like pulleys for the long tendons, improving efficiency. And the interosseous membrane binds tibia and fibula tightly.
Compartments again, like the thigh, but 3 this time, and prone to issues.
Yes, deep fascia, septa, and the interosseous membrane divide the leg into anterior, lateral, and posterior compartments, each with its own muscles, blood supply, nerve supply. And yes, compartmentalization means risk.
Let's start anterior. Contents, actions, clinical risk.
Interior compartment has tibialis anterior, extensor digitorum longus, fibularis tertius, extensor hallucis longus, main action, dorsiflexion at the ankle, lifting foot up. Also inversion, tibialis anterior, extensor hallucis, and inversion fibularis tertius, blood supply, anterior tibial artery, nerve,
Good.
a deep fibular peroneal nerve.
And the clinical risk, compartment syndrome.
What's fascinating and dangerous is anterior compartment syndrome, swelling inside that tight space, often after a fracture. Pressure builds, causes deep aching pain, worse with foot movement. Venous return gets choked off, pressure spirals, severe cases. Artery supply cut off, lose dorsalis pietis pulse, muscles paralyzed. Specific sensory loss only in the web space between first and second toes, deep fibular nerve. It's an emergency needing fasciotomy, cutting the fascia to release pressure and save the muscles.
Okay. Lateral compartment. Muscles.
Lateral compartment contains just 2 key muscles, fibularis longus and fibularis brevis, actions. Plantar flex the ankle, point foot down, and avert the foot, sole outwards. Very important for holding up the lateral longitudinal arch. Fibularis longus tendon also supports the transverse arch. Blood supply from fibular artery branches. Nerve, superficial fibular, peroneal nerve. Their tendons run behind the lateral malleolus, prone to tenosynovitis or dislocation of the retinaculum tears.
And the posterior compartment, superficial and deep groups.
Yes, a deep transverse fascia divides it. Superficial group, gastrocnemius, plantaris, soleus. Collectively, the triceps surae, powerful plantar flexors, insert via the common Achilles tendon onto the calcaneum, main engine for pushing off when walking or running.
And prone to injury, Achilles rupture.
What's fascinating is the force they handle and their vulnerability. Calf muscle tears, gastroc soleus, cause severe pain, swelling. Achilles tendon rupture is common in sports, usually tears at its narrowest part, couple inches above the heel. Sudden sharp pain, can't walk properly, palpable gap, can't actively plantar flex, needs surgery.
Below them, the deep group, and a link to DVT.
Deep group includes popliteus, flexor digitorum longus, flexor hallucis longus, tibialis posterior. Whole posterior compartment gets blood from posterior tibial artery, nerve supply from tibial nerve. And this raises an important issue, especially for travelers. Deep vein thrombosis, DVT.
Right.
Immobility, like long flights, increases risk, especially in the deep veins within the soleus muscle, can cause calf pain, tightness, or be silent. Danger is a clot breaking loose pulmonary embolism, potentially fatal. Professionals, stress prevention, leg stretching, movement.
Okay, ankle and foot now. Intricate unit. Ankle is a transition zone.
What's fascinating is how precisely everything is organized passing the ankle. Crucial for surgeons. Anteriorly superficial. Saphenous nerve vein medially, superficial fibular nerves laterally, deep to retinacula, medial to lateral, tibialis anterior, extensor hallucis longus, anterior tibial artery vein, deep fibular nerve, extensor digitorum longus, fibularis tertius, all tendons and synovial sheaths.
Behind the ankle bones.
Behind medial malleolus, deep to flexor retinaculum, medial to lateral, tibialis posterior, flexor digitorum longus, posterior tibial artery vein, tibial nerve, flexor hallucis longus, each tendon sheathed. Behind lateral malleolus, deep to superior fibular retinaculum, fibularis longus and brevis tendons in a common sheath initially.
Foot sole now. Plantar side. Support, leverage, adaptation.
Foot is an engineering marvel. Supports body weight, levers us forward. Segmented structure makes it pliable, adapts to uneven ground, absorbs shock. Skin is thick, hairless, bound down tightly, lots of sweat glands. Deep fascia forms the thick plantar aponeurosis, protects structures underneath. Apex attaches to calcaneum.
Plantar fasciitis are related to this. Calcaneal spurs.
This raises a common issue for people on their feet. Plantar fasciitis, pain tenderness in the sole, often from repeated minor trauma to that aponeurosis. Chronic irritation can cause bone formation at its attachment, a calcaneal spur. Key finding for professionals.
Muscles of the sole, 4 layers, mainly for arch support.
Muscles are in 4 layers, superficial to deep. First layer, abductor hallucis, flexor digitorum brevis, abductor digiti minimi. Second, quadratus plantae, lumbricals, long flexor tendons. Third, flexor hallucis brevis, adductor hallucis, flexor digiti minimi brevis. Fourth, interosse fibularis longus tibialis posterior tendons. Unlike the hand, these are primarily for supporting the foot's arches, less about fine toe movements. Critical distinction.
Sole's blood supply. Plantar arch.
Posterior tibial artery divides behind medial malleolus into medial and lateral plantar arteries. Lateral plantar artery is bigger, runs deep, curves medially at the fifth metatarsal base to form the plantar arch, connects with deep plantar artery from the dorsalis pedis, robust supply to the toes.
Nerves of the sole.
Well,
Tibial nerve splits. Comparison to hand nerves.
what's fascinating is the parallel. Tibial nerve divides behind medial malleolus into medial and lateral plantar nerves. Medial plantar nerve is like the median nerve in the hand, supplies muscles like abductor hallucis, flexor digitorum brevis, first lumbrical, skin of medial 3.5 toe. Lateral plantar nerve is like the ulnar nerve, supplies quadratus plantae, abductor digiti minimi, skin of lateral sole. Its deep branch gets adductor hallucis, other lumbricals, interosse, comprehensive innervation.
Dorsum of the foot now. Top side, skin, different. Vessel's key.
Skin on top is thin, hairy, mobile, like back of the hand. Most blood drains into the dorsal venous arch over the metatarsal heads. Visible network. Drains medially into great saphenous, laterally into small saphenous.
Arterial supply. Dorsalis pedis pulse.
Dorsalis pedis artery, continuation of anterior tibial, is the main supply here. Superficial, often easily palpable between extensor hallucis longus and extensor digitorum longus tendons, midway between malleoli. Critical pulse point for checking lower limb circulation.
Right, let's talk joints now. Hip joint first. Ball and socket, built for strength.
What's fascinating is the hip's blend of strength and mobility. Synovial ball and socket. Femoral head in the deep acetabulum. Acetabular labrum deepens the socket. Capsule is strong, reinforced by powerful ligaments.
The iliofemoral ligament.
The iliofemoral ligament inverted Y shape is incredibly strong, prevents hyperextension when standing. Pubofemoral limits extension abduction. Ischiofemoral limits extension. Inside, the ligament of the head of the femur carries that small artery branch, vital in kids. Movements are wide-ranging. Flexion, extension, abduction, adduction, rotations. Extensors and lateral rotators are particularly powerful.
Relations matter clinically. Sciatic nerve, referred pain.
Anteriorly, related to iliopsoas rectus femoris. Posteriorly, deep rotators separate it from the sciatic nerve-critical relationship. Nerve can be injured in dislocations, and this raises the issue of referred hip pain.
How does that work?
Femoral nerve supplies the hip and skin of anterior medial thigh. Obturator nerve, posterior division, supplies both hip and knee joints, so hip problems can present as knee pain, diagnostic challenge professionals face.
Congenital and traumatic dislocations.
Yeah.
Trendelenburg sign.
Congenital hip dislocation, more common in girls, needs early diagnosis treatment. Traumatic dislocation is rare due to strength, usually high-energy trauma, often posterior. Sciatic nerve is at high risk. Hip stability on one leg relies on gluteus, medius minimus, normal hip anatomy. If any part fails, you get that positive Trendelenburg sign, pelvic drops on the unsupported side. Waddling gait, if bilateral. Osteoarthritis is common, causes pain, often referred. Stiffness, characteristic deformity, flexion, adduction, external rotation.
And that of vascular necrosis again. Femoral neck fractures.
Indeed, femoral neck fractures often tear those crucial retinacular arteries from the medial circumflex femoral, compromises blood flow. If the artery in the ligament of the head isn't enough, a vascular necrosis occurs. Also possible in kids after dislocations, underscores knowing the vascular anatomy.
Moving to the knee. Largest, most complex joint. Engineering marvel.
The knee truly is. Two main parts. Femur condyles, articulating with tibial plateaus and menisci, and the patella gliding on the femur. Fibula is not directly involved. Synovial hinge allows some rotation. Capsule reinforced by ligaments. Extracapsular and intracapsular.
Intracapsular, the cruciates. Vital but vulnerable.
Here's where it gets really interesting clinically. The ACL and PCL cross inside the joint. Main bond between femur and tibia lie behind the synovial cavity. ACL prevents tibia sliding forward on femur. PCL prevents it sliding backward.
ACL tears common.
Most frequently surgically repaired ligament in the body, more common in women, usually injured with other structures, causing swelling, blood in joint, hemarthrosis. Positive drawer sign on exam confirms rupture, excessive forward movement for ACL, backward for PCL, key diagnostic tests.
Menisci, also critical, can lock the joint.
The menisci C-shaped cartilage shock absorbers deepen the joint surface. What's fascinating is the medial meniscus is less mobile because it's attached to the MCL, makes it more prone to injury than the lateral one.
How do they tear?
typically from twisting on a slightly bent, weight-bearing knee, can cause a split, like a bucket handle tear. If the torn piece flips into the joint, it wedges between the bones and locks the knee. Needs diagnosis via imaging or arthroscopy.
Knee movement isn't just hinge, locking and unlocking.
This raises an important point about stability. In full extension, the knee locks femur, rotates medially on tibia, tightening ligaments, rigid structure. To start bending, it must unlock. The popliteus muscle does this, rotates the femur laterally on the tibia, slackening ligaments, then flexion can happen. Knee stability relies most on quadriceps muscle tone, then ligaments.
Ankle joint now. Strong, stable hinge.
Exceptionally strong and stable hinge. Lower tibia and malleoli form a deep socket, the mortise, gripping the talus. Medial deltoid ligament is strong, resists eversion. Lateral ligament is weaker, 3 bands, resists inversion.
Movements. Inversion happen elsewhere.
Primary movements are dorsiflexion, foot up, and plantar flexion, foot down. Inversion and aversion happen at the tarsal joints below the ankle, not the ankle joint itself. What's fascinating is how stability changes. In dorsiflexion, the wider front part of the talus wedges into the mortise, tightening ligaments, making it super stable for push-off. Sprains are common lateral sprains, inversion tear lateral ligaments. Medial sprains, aversion, often pull off the medial malleolus tip instead of tearing the strong deltoid ligament.
Below the ankle, the tarsal joints add complexity. Inversion happens here.
Yes, the joints between tarsal bones are key. Subtalar joint, talus calcaneum, and the transverse tarsal joint, talocalcaneonavicular plus calcanea cuboid, are where inversion and eversion primarily occur. Inversion, sole medially, is greater, done by tibialis anterior posterior long toe extensors. Eversion, sole laterally, by fibularis muscles. Professionals know this distinction is vital. Hallux valgus, bunion, affects the big toe's metatarsophalangeal joint, common issue leading to hallux rigidus, stiff, painful joint.
Okay, let's look at the foot as a functional unit now. Arches are key. Support and propulsion. Professional level biomechanics.
What's truly fascinating is the foot's dual role. Supports weight, acts as a propulsion lever. Segmented structure allows pliability, shock absorption. Central to this are the 3 arches: medial longitudinal, lateral longitudinal, transverse. Formed by bones, maintained by ligaments, and dynamic muscle support.
How are the arches maintained? Bones, ligaments, muscles. Engineering analogy.
It's a marvel, like a stone bridge. First, bone-shaped, wedge-shaped bones. Talus is keystone for medial arch, cuboid for lateral. Second, inferior edges tied together by strong plantar ligaments, like plantar calcaneonavicular and tibialis posterior tendons. Third, tie beams plantar aponeurosis, intrinsic muscles, long flexor tendons prevent end spreading. Fourth, suspension from above, tibialis anterior posterior fibularis muscles sling the arches up.
Is it passive structures or active muscles supporting the arch when just standing? Key distinction.
This raises an important point. Research shows that when just standing still, muscles like tibialis anterior and fibularis longus are often inactive. Static support comes mainly from bone shape and ligaments, but during walking or running, these muscles become highly active, providing crucial dynamic support. Prolonged standing, especially if overweight, strains ligaments, leads to flat feet, pes planus. Good muscle tone helps sustain arches dynamically. Propulsion involves heel lift, toe extension, tightening the plantar aponeurosis, heightening arches. Calf muscles provide power, toe flexors give final push.
Other clinical issues? Bursitis?
Bursae reduce friction. Bursitis is inflammation, often from trauma or overuse. Common sites: prepatellar, infrapatellar bursae at knee. Some bursae communicate with the knee joint, like the suprapatellar. If the knee swells, these bursae can distend. Adventitious bursae can form from abnormal friction. A bunion is one over the big toe's metatarsal head.
Briefly, embryology. Limb rotation, congenital issues.
Limb buds appear week 6. What's fascinating is the lower limb bud rotates medially during development. Explains the spiral dermatome pattern and why the big toe is medial. Disruptions cause issues like ectromelia, missing limb part, or talipes, clubfoot, often needing orthopedic care.
Okay, final stretch. Practical applications. Radiology, surface anatomy. Key for professionals.
Absolutely. Plain x-rays show bones beautifully. Shenton's line, fractures. MRI is great for soft tissues, ligaments, muscles. But hands-on surface anatomy is paramount for exams.
Critical, palpable landmarks.
What's fascinating is how much you can feel. Gluteal, iliac crests, ACC success, ischial tuberosity, greater trochanter, can estimate sciatic nerve path, inguinal, ligament, pubic tubercle, femoral triangle, feel femoral artery pulse, mid-inguinal point. Knee, patella, ligamentum patellae, tibial tuberosity, condyles, joint line, can roll common fibular nerve below fibula head. Leg, Tibia's anterior border medial surface are palpable all the way down. Ankle, malleoli. Feel posterior tibial pulse behind medial malleolus, dorsalis pedis pulse on top of foot. These pulses are vital checks for circulation.
Comprehensive clinical notes on arteries. Palpation, collateral circulation, disease.
Arterial palpation is basic, essential. Femoral, popliteal, dorsalis pedis, posterior tibial. Collateral circulation is key backup. Cruciatric-enteric anastomosis near hip. Perforating branches in thigh. Gradual blockage, atherosclerosis, allows collaterals to enlarge, often preventing gangrene. Sudden blockage, embolism, is often catastrophic. Arterial occlusive disease causes intermittent claudication, exercise-induced calf pain relieved by rest. Lumbar sympathectomy is a surgical option to improve blood flow.
And finally, comprehensive clinical notes on nerves. Reflexes, specific nerve injuries. Back to our student.
What's fascinating is using reflexes to test spinal segments. Patellar reflex, knee jerk, tests L2, 3, 4. Achilles reflex, ankle jerk, tests S1, S2. Invaluable neurologically.
Specific injuries.
Femoral nerve injury, rare. Affects quads, can't extend knee. Sensation loss, anterior medial thigh leg. Sciatic nerve injury, often from injections. Hamstrings affected, but critically, all muscles below knee paralyzed. Leads to foot drop. Major sensory loss below knee except saphenous area. High risk of trophic ulcers on sole.
And full circle, common fibular nerve injury, the student's case.
Indeed.
Yeah.
What's truly key here is its vulnerability around the fibula neck. Direct trauma, like the bumper, fractures, casts. Injury paralyzes anterior and lateral compartments. Causes foot drop, equinovarus deformity. Sensory loss on anterior lateral leg. Dorsum of footos, sparing lateral border sole. Precisely matches our student. A perfect example of applied anatomy yielding a diagnosis.
Tibial and obturator nerve injuries are rarer.
Tibial nerve is deep, rarely injured. Paralysis affects posterior leg sole muscles, calcaneovalgus foot. Sensory loss on sole, ulcers. Obturator nerve injury, also rare. Affects adductors, except hamstring, part of Magnus. Minimal sensory loss.
Wow, what an incredible detailed journey through the lower limb. From the os coxos and femur's architecture, through compartments, muscles, nerves, vessels, to the foot's engineering. We really have taken that deep dive. Complex, resilient, yet vulnerable.
We've seen exactly how specific details like that vulnerable path of the common fibular nerve directly explain clinical pictures like foot drop. That professional-level grasp of anatomical relationships isn't just academic, it's the absolute foundation for diagnosis, treatment, rehabilitation. It lets us appreciate the body's amazing design and how its vulnerabilities teach us just as much.
It is humbling, thinking how every tiny structure plays a role in just letting us stand and walk. Next time you take a step, maybe you'll think about that incredible anatomical symphony.
And for you, the learner, remember true mastery isn't just listing parts, it's understanding the integrated function, the clinical stories anatomy tells. This deep dive is just the start of a lifelong exploration. Keep questioning, keep exploring, keep connecting those dots. Move beyond facts to that profound professional appreciation.